Hey everyone, and welcome to the Explainers. So glad you're here with us. We are diving straight into one of the absolute most dramatic, and honestly, kind of fascinating, pediatric gastrointestinal emergencies you're ever going to see. Whether you're a nursing student prepping for exams, a seasoned healthcare pro, or just a really proactive parent, understanding this stuff is a total game changer. We're tackling a big, intimidating medical word today, but I promise it has a completely logical progression. We're taking intussusception from a total medical mystery to a concept you can absolutely master.
Okay, picture this. Why would an otherwise perfectly healthy, happy infant suddenly let out this piercing, inconsolable scream, pulling their knees completely up to their chest in just absolute agony? And then, maybe 10 minutes later, they're fine. Totally calm, looking completely normal. Well, this terrifying roller coaster of a presentation is the classic hallmark of our medical mystery today. It is a giant, flashing red flag telling us that something mechanical is going very, very wrong inside the gut.
So what exactly is the culprit here? It's a condition called intussusception. Now, what that actually means is a proximal, or upstream, segment of the bowel literally telescopes inside a more distal, downstream segment. It just slides right inside itself, pulling the mesentery, that's the tissue attaching the intestines to the abdominal wall, along with it. And get this mechanical telescoping is actually the #1 most common cause of intestinal obstruction in kids between 3 months and 6 years old. Sometimes it's triggered by a physical point, like a polyp, but honestly, most of the time, it's just idiopathic. It often happens right after a simple viral infection that causes the intestinal lymph nodes to swell up. Now, let's talk about where this traffic jam actually happens. The most common spot for this telescoping to occur is right at the ileocecal valve. This is called an ileocolic intussusception. It's where the end of the small intestine, the ileum, just folds right into the cecum and pushes further down into the colon. You can imagine how the blood vessels get dragged in between those layers of bowel and literally physically trapped. It's kind of like when you fold a pair of socks inside out and everything gets jammed up in the middle. But this isn't just a simple blocked tube, right? It's a compromised blood supply, and it kicks off a very strict 4-step chain reaction. First up, that mesentery gets totally compressed and kinked inside the telescoped bowel. Step 2, this causes a backup, lymphatic and venous obstruction. Everything starts swelling and the pressure just builds and builds. Then, step 3, when the pressure inside that swollen tissue actually equals the patient's arterial pressure, fresh blood flow completely stops. That means ischemia. The bowel is literally starving for oxygen. And finally, step 4, because the tissue is getting so engorged and starting to die, mucus and blood just start pouring right into the intestinal tract. And that specific chain reaction brings us to literally one of the most famously tested, absolutely critical symptoms in all of pediatric medicine: the passage of red, currant jelly-like stools. Here's why this happens. When that oxygen-starved bowel leaks venous blood and a ton of mucus into the tract, they mix together. By the time it actually passes out of the body, it looks exactly like red currant jelly. I mean, it's unmistakable. This is not just regular bleeding, folks. This specific jelly-like stool is the absolute hallmark of intussusception. If you hear this or see this, your alarm bells need to be ringing at maximum volume. So let's recap those cardinal warning signs. First, you've got that sudden, acute abdominal pain, the child screaming, pulling their knees up, followed by those eerie, quiet periods where they look totally fine. As things get worse, you're going to see bilious vomiting and the child getting more and more lethargic. But here are the real memory hooks for your physical exam. You might actually feel a literal sausage-shaped mass in the upper right quadrant of the belly. That's the telescoped bowel itself. And meanwhile, the lower right quadrant, it feels unusually empty. We actually call that emptiness the dance sign. Now, feeling a sausage-shaped mass or noticing that dance sign, those are huge clues. They point us right to the problem. But modern medicine means we need objective, definitive proof before we go doing any procedures. That's where ultrasound comes in. When the tech scans the abdomen, they're looking for a very characteristic heterogeneous mass that looks exactly like a bullseye or a target. That bullseye is literally the cross-section of the bowel layered inside of itself. It's fascinating, and it confirms exactly what we're dealing with. Okay, so we've got our diagnosis, or maybe we just highly suspect it. What's the very first thing we do? We stabilize. This is a strict clinical rule. The first therapy is IV fluids if the patient has no PO intake, meaning they aren't taking anything by mouth for any reason whatsoever. Think about it. Before anyone even tries to untelescope that bowel, you've got a baby who's been vomiting, is definitely dehydrated, and could honestly be heading straight into shock. Preoperative hydration and fixing those electrolyte imbalances, that is absolute non-negotiable step 1. Building right on top of that stabilization is our pre-procedural nursing assessment. First things first, strict NPO. Nothing by mouth, period. We have to watch like a hawk for signs of aspiration, continuous vomiting, and of course, dehydration. And you've got to really assess that vomit. What's in it? How much is there? What color is it? Is there bile? Is it red? Every detail tells us how bad the obstruction is. And finally, giving prophylactic antibiotics. This is crucial to prevent a massive systemic infection because remember, that bowel is highly compromised right now and at a major risk of perforating. All right, so how do we actually fix this telescoped bowel? Well, the really amazing thing about intussusception is that usually we don't even need surgery. We use conservative enema treatments to literally just push the bowel back into its proper place. There are two main options here. First is a radiologist-guided pneumoenema, which uses air or gas, and that has a really fantastic 83% success rate. The other option is an ultrasound-guided hydrostatic enema, which uses fluid. That one sits about a 70% success rate, but the huge advantage there is absolutely no ionizing radiation for the child. Surgery, that's really only on the table if these enemas fail, if the bowel has already perforated, or if the patient is super unstable. You know, if you ever find yourself having to explain this hydrostatic enema to terrified parents, and you will, use the rubber glove analogy. It is a brilliant way to explain it. Tell them to imagine you've taken the finger of a rubber dish glove and poked it inside out, right down into the palm of the glove. That's the intussusception. Now, how do you fix that without reaching inside? You just fill the glove with water. The hydrostatic pressure of the water naturally pushes that finger back out until it pops into its normal shape. And that is exactly what the fluid does to their little one's bowel. It's pretty amazing when you think about it.
Okay, so the bowel is back in place, whether by enema or surgery. Are we done? Definitely not. Now we transition into continuous post-op care. We are keeping a super close eye on those IV fluids, and you really need to reassure the parents here. Post-operative vomiting is actually super common for the first 24 to 48 hours. Don't panic, it's expected. We also have to track every drop of stool output, noting exactly what's happening, like writing down 180 stool out. Oh, and here is a critical, absolutely non-negotiable rule. Measure nothing up the butt. No rectal temps, no suppositories, nothing. That tissue has just survived immense trauma and it is incredibly fragile. Just leave it alone.
And finally, we are always on the lookout for the ultimate victory sign. This is a massive nursing alert, the passage of a normal brown stool. Honestly, this usually means the intussusception has totally reduced itself. Whether this happens spontaneously right before treatment or after you've done your interventions, a normal brown stool means the plumbing is officially back online. The ischemia is gone and the bleeding has stopped. The second you see this, you report it to the practitioner immediately. The medical mystery is solved, and hey, it might just cancel a scheduled surgery entirely. Well, we've covered the mechanics, the cardinal signs, those unforgettable red currant jelly stools, and the totally brilliant enema solutions. So I want to leave you with a question to chew on. How are you going to use these red flags to spot the really subtle signs of a bowel obstruction before things progress? Whether you're assessing a tiny patient in the ER or just keeping an eye on your own kid at home, realizing that those quiet, calm periods between severe pain aren't actually signs of recovery but a classic symptom of a mechanical blockage, that knowledge can literally save a life. Keep these lessons in your back pocket, stay vigilant out there, and never stop learning. Thanks so much for hanging out with me for this explainer, and I'll catch you next time.